Liebe Kolleginnen und Kollegen, liebe Freunde des Amboss-Studientelegramms, Marcus at home welcomes Dr. Behnood Bikdeli in Boston, Massachusetts, with whom we would like to discuss if, when, and how to prevent venous thromboembolism in patients affected by COVID-19. Now, Dr. Bikdeli is affiliated to a couple of Ivy League medical schools, such as Harvard Medical School, Yale School of Medicine, Columbia University. He's the principal investigator of the first large randomized trial that tested the effects of anticoagulation in people with COVID-19, and he's coordinating the global cooperation of different studies in that field, and he has published a couple of JACC and other papers in the last weeks. My co-moderators are Anja Scheuer from Frankfurt, Germany, and Dr. Steag von Schirmer from Kaiserslautern and Homburg in Germany.
Good morning from me too. My first question would be about the high thrombogenicity in COVID-19 patients, because we know that venous thromboembolisms are very common in inflammatory diseases, including viral infections. So is the risk higher in COVID-19 patients? And if it is, then do you know the mechanism of that?
Good morning, and thank you very much to be with all of you. Good evening, your time. It's really a pleasure. So I think over the past year or so, we've all recognized so many thrombotic events, both on clinical practice and in terms of publications that have come out that have drawn people's attention. At this point, I think it is fair to say COVID-19 is associated with increased risk of thrombosis compared with our usual patients who get hospitalized. And for that, there are several hypotheses that are being driven. If I were to encapsulate, probably what I can say is the Virchow triad is at play. So from one end, we have a hypercoagulable state in part because of endothelial activation. So the second part of it is endothelial activation itself. And the third one is many of these people get sick, they are ill, and they also have several comorbidities. So stasis could come at play. Last but not least, outside of this triad is a lot of them have a high risk of thrombosis to begin with. So just imagine what happens when all this triad occurs in these high-risk people. So the only other piece that I want to share, I think what we've learned since last year is that the risk is high, the risk is significant, but probably a little less than what we had initially anticipated in March 2020. Reason I'm saying that is there's at least 2 systematic reviews that have been published that quote that the pooled event rates are a little lower than we expected. I'm happy to dig deeper and discuss that more in a few minutes.
Just wanted to start right there. Mechanism-wise, do you think, or talking about Virchow's triad, that's talking about venous thrombosis, obviously, and VTE. Now, from cardiology point of view, we see a lot of microthrombi in the heart, in the microvasculature, probably much more than direct viral problems with the cardiomyocytes. It all seems to be, we're talking about endothelitis. What's the issue there? Why do we see venous thrombosis on the one hand and then arterial, maybe inflammation-triggered problems on the other hand?
That's a great question. Maybe I will take a step back first and then get to your specific question. Maybe 30, 40 years ago, people used to think venous thrombosis and arterial thrombosis are 2 very separate entities. But the myth has been somewhat dispelled. Paolo Prandoni from Italy and others have shown that they actually share a lot more in common than differences, endothelial function being one. So fast forward to COVID-19, I think one of the key issues is this exuberant immune response to the extent that it promotes several of the procoagulant factors, not to mention if the endothelium is inflamed and or diseased and activated. It's similarly going to increase the risk of thrombosis on both sides. Now, as you appropriately mentioned, on the arterial end, we don't get to see too many macrothrombotic events. There are some, but not dramatic. A lot of it is microthrombosis.
Yeah, very interesting. And coming from the way that these things evolve, obviously, we're very, very interested, and you published a lot of that already in review articles also. What do we best do to prevent things? And that's a huge field, really, and you mentioned that, and put it up so nicely and systematically in your work, from people being outpatients, coming inpatient on the medical ward, then being more sick, and then finally ICU treated, or post-COVID. Really, I mean, in the general practice, we see a lot of post-COVID-19 patients. Some of them were mildly symptomatic in first place, and then by their GP, they get treated with aspirin, because that might help, supposedly. Probably doesn't, but could you maybe, I know that's a bunch of questions in one, but kind of lead us through this whole field of
Sure.
The disease, and what do you think which we need to do, and where's the data? A little bit of data you just recently published, of course.
Of course, I cannot agree more with you about the importance of the questions that you posed. So I think the more knowledge that we generate about the disease pathophysiology, presentation, et cetera, they're all important. But if there is one area that is arguably the most important for patients, clinicians, and policymakers, is what do we do to help patients live longer, better, or both? And for that, I think the best way to move forward is to inform our knowledge and practice by randomized trial data, because time and time again, history has proven us wrong when, with the best of intents, we've done the things that not only didn't help patients, but also occasionally harmed them. You're interested in cardiology, so let's take the CAST trial as an example. So we all thought that PVCs are so bad post-MI, and then we started treating it with flecainide and others, and guess what happened? Increased cardiovascular events, despite the fact that we presume PVCs are bad. So I'm concerned that more of the same happens here. That is part of the impetus that our group tried to generate some systematic summary of ongoing trials. So to your specific question, I think there are different issues at hand. One is the patient disease severity. So outpatients, patients on the floor, patients in the ICU, and then post-discharge patients who could be at risk of long COVID, as you're mentioning. And then we have an armamentarium of agents. For example, on the inpatient side, we have heparin-based regimens, bivalirudin, deniparoid, a lot of others. And in the outpatient realm, we have drugs like aspirin, P2Y12 platelet receptor antagonist, but also direct oral anticoagulants, among others. And really key becomes, what do we have to inform practice? Just as a 30-second summary for outpatients, we have one positive trial with sulodexide that came out from Mexico. It's not conclusive and has some biases. So I'm interested in that agent and seeing how that goes forward. Patients on the floor, we have preliminary results from the multi-platform trial, not published or peer-reviewed yet, but some hope. For ICU, our very own inspiration trial, plus preliminary results from the multi-platform trial, so far do not suggest that heparin-based regimens on an escalated basis help. And for post-discharge patients, it's still a very big open question. So if I were to encapsulate everything for the moment, for the most part, we don't know. But if someone were to care about his or her patient, my humble recommendation is to enroll them in a randomized trial or just to stick with standard of care, except for very rare exceptions.
Thank you. Talking about the inspiration trial that you led yourself, and we just published the 3-month results. What was the exact idea on? Because I found that very interesting. I went back and forth between prophylactic anticoagulation and therapeutic dose, and then you went for this intermediate dose, which is about half of therapeutic. What exactly is the reason there? Is it going for the best way through the middle, or is it? What did you
that's a great question. So part of the impetus was based off of the experience when I had in New York. We helped work on a separate trial named IMPROVE, which is still ongoing at Columbia. And at the time when we were discussing, there was a lot of concern that we want to find a sweet spot trying to mitigate this thrombosis phenomenon, but also not causing so many bleeding events, because PROTECT and other studies had shown major bleeding events could be as high as 5.5 to 6% in patients who are admitted in the ICU. Not to mention early on, many people were concerned about DIC in patients with COVID-19. And we didn't have the recognition that even if there is some component of that, it's more so on the hypercoagulable side rather than hemorrhagic features. So we, as you said, we were thinking maybe intermediate dose would be sufficient to mitigate the thrombotic events while not causing too many bleeding events. That's the thought process. And initially, we published the 30-day results in JAMA now almost 2 months ago, where we showed that intermediate dose anticoagulation compared with standard dose prophylaxis did not confer a benefit for the composite of venous or arterial thrombosis or all-cause mortality. Now, the open question was, as you said, many of these people have a longer term period of risk, or at least that's what we perceived. So we decided to follow them for 90 days and see what happens, in part in the context that patients, irrespective of their discharge status, were receiving treatment for the first 30 days. So we wanted to see what happens by day 90. And in essence, we didn't see a different signal when we followed up to 90 days either.
But finally, the bleeding endpoints, I mean, we're talking about the thrombotic and ischemic endpoints that was comparable between the two groups. It didn't go at any cost, where there's no benefit, there's no cost of bleeding, really. What did it? I mean, one could, on the other hand, argue it didn't do any harm either, or not much of it.
I probably agree with the latter. Reason being, if you look at the numbers that we quoted, first, severe thrombocytopenia was only observed in people who had received intermediate dose anticoagulation. Granted, it was few numbers, but 6 versus 0. And then once you got to the bleeding events, again, the absolute event rates was fairly low, which is reassuring. And these were all blindly adjudicated events. That being said, there was a non-significant trend. So I think and I've heard it from some colleagues, but the question that I would have, if you have clear evidence of no benefit, even if it's not showing any major harm, why would you want to use it in routine practice? If somebody says there was no signal for harm, I want to trial it in a 2,000 patient trial, I might beg to differ, but I would understand that rationale. Not so much for routine practice.
So what we like, particularly in Inspiration, so as Anya and me are working in kidney disease and nephrology, if I got you right, you included patients down to a creatinine clearance of 15 or even lower. So even some dialysis patients might have been included, if I got it right.
That is absolutely correct. And we were working closely with a team of clinical pharmacists who recommended dose adjustment in these patients, including for people who had ESRD. Essentially, we were reverting back to unfractionated heparin for safety reasons. But that is correct. We did not exclude people with severe renal dysfunction. As you might have seen in the I should say, parallel study that we published in JACC, several of the other studies actually exclude these patients or even pregnant patients and other subsets. And I think that's a very important point, because some of these patient populations are actually more vulnerable. And by the easiest thing is to exclude them, but by excluding the more vulnerable patients, you're going to have no answer when it becomes the more clinical challenging of patients that we encounter at bedside.
Yeah. And you also adjusted very thoughtfully for different levels of kidney function, which again, for us as kidney doctors is really thrilling to read. I'm curious for another question. So you are based on the East Coast, you are at Boston, and how comes that the study has been done in Iran, in Tehran, and a second city, if I'm right, in Iran?
Of course, that's a great question. Well, part of it is I have a Persian background, and I've been fortunate to have many friends and colleagues there. But essentially, it was a series of initial conversations, totally off topic, for something else that I had with a friend of mine, my joint PI of Inspiration, Dr. Sadiqipour. And while in the middle of the pandemic, both of us were devastated by hearing the difficult news all around the world. And we thought maybe that's one way that we could try to generate some information that could be helpful to all patients and clinicians all around the world. So believe it or not, in a span of 30 days, from the first initial informal conversation that we had, we wrote the full protocol, we got IRB approval, we got the study drugs, and we enrolled the first patient less than 30 days from initial conversation. But that's how it happened.
And maybe once again, coming back to the low platelets, because there were quite a couple of patients who had very low platelets when receiving high dose or intermediate dose, at least, heparin. do you believe this to be kind of a hit phenomenon, or how comes that people go down with their platelets if they receive a higher dosage of heparin?
That's a very good question. In part, unfortunately, because of funding limitations, we were not pre-specifying to look into the reasons for severe thrombocytopenia. But of course, escalated dose heparin, it's a very, very reasonable concern. That's at least some of those cases may have been related to HIT. And in a few of them, clinically speaking, heparin products were stopped. When we looked at other subgroups of thrombocytopenia, including less severe cases, there was actually not much of a signal. So I think we should also take it with a grain of salt because the safety outcomes were not adjusted for multiplicity. If I were to guess, I would potentially take it seriously, but because it was not adjusted for multiplicity, I would also like to see the results from other trials before I make conclusive remarks about it.
Speaking about thrombocytes, what's your thought? I know the inspiration trial was with a low molecular weight heparin. What's your thoughts on unfractionated heparin? Because I know at least in Germany on the ICUs, that's usually what is used just because people feel more flexible with the dosage, and maybe very sick patients going towards ECMO, there would be an unfractionated heparin as well. Would you just from a feeling, gut feeling, would you think that might be I know how difficult it is to keep people in a range of if you PTT control it. I mean, it usually never works in my experience, but what's your thoughts there?
That's a great point. And I think for us as internists and those interested in cardiology, it's very tricky even outside of COVID-19. Take people with acute pulmonary embolism or acute coronary syndromes. We have had studies on either sides, and many people are proponents of low molecular weight heparins because of better bioavailability and more predictable dosage. That being said, I can totally resonate with you, having worked in the ICUs in the COVID days, that many of these people are going to need lines and whatnot, arterial lines, venous lines, ECMO, one of the more prominent ones. And it's tough to do that if they receive the full dose of low molecular weight heparins 2 hours prior, versus with heparin, you're going to shut it off and 1 hour after you're going to be okay. So I think part of it should also be based off of what the institutional champions are comfortable with in terms of using them, because I have seen some hospitals wherein even low molecular weight heparins could be fairly safely used, even in the ICU setting, because few of the procedures are truly emergent, even in the ICU. Say, even if you want to give pressors for 6 hours or 8 hours, you can do them peripherally until you're out of the woods, and you can place your line a few hours after. But if it's really a very dynamically ill patient, I completely agree with you that unfractionated heparin would be very reasonable.
So for the time being, surely everybody would be happy to see all people included into randomized clinical trials, but surely that's not what happens. And if we got your results and the yet to be published results from the other large trials correctly, then there should be no intermediate dose or high dose anticoagulation in COVID-19 people who are on the ICU, because there was either no benefit or even some harm. And I mean, there have been some severe bleeding events in Inspiration, if I remember that right. And what about the people who are on general medical wards and who cannot be included into clinical trials? Because here we have some preliminary data that suggests potential benefit from ACTIV-4 and the other large studies.
That's another great question. So let me address the last part first and then share some other parts. I'm very interested in seeing the full results of the multi-platform trials. That being said, at least as far as I'm aware, the investigators have disclosed that those were site-reported events, not adjudicated. So chances are that even those would be subject to change once adjudicated and reported subsequently. But I remain very excited and interested. Also, there are several other trials, Freedom and Rapid being two, but many others ongoing. So I think all of them are going to inform us for floor patients. The other piece to it, really, in my humble opinion, is maybe it's not a one-size-fits-all situation. So does it have to do with some of the biomarkers, and we know that some of the trials are D-dimer based, but maybe it's not just the D-dimer, maybe it's the level of D-dimer. Would it matter if it's greater than, for example, 5,000 as opposed to just being positive about 500 or 1,000? Does it have to do with the acuity of presentation? For example, some people think it's really the early on phase that if you catch the patients, you're going to make a difference, as opposed to somebody who was having lingering symptoms and 10 days in, because of severe tissue damage in the lungs, they got hospitalized with hypoxemia. Maybe the damage is done by that time. So I think those are all open questions that should be answered hopefully very soon. And one more thing that, if I may, I wanted to touch upon is that the pandemic has brought a lot of collaboration, and we see great efforts in trials. But one thing, as somebody involved in and interested in clinical trials, that I wish we would have seen a different way is I would have loved to see less of trials and essentially fewer higher quality studies, because we've seen so many studies, some of which are really designed nicely, but small single center or from 2 centers, and they're going to enroll few patients, and the results are going to be subject to huge heterogeneity. Imagine instead of 45 trials or 75 trials, many of which had small sample sizes, what if we have 10 or 15 of them with more definitive, conclusive designs? I think we would have been better off. That being said, I can only imagine how difficult it would have been to coordinate.
Could you speculate? One more question, Gunnar. Sorry if I come in again about antiplatelets. You alluded to it very quickly. What are the ongoing trials there? I'm not quite sure. Obviously, we're in a very difficult situation with post-discharge patients who are. We need much larger numbers because the patients, the events will be small. Is there any? Do you think there will be any conclusive data on aspirin, clopidogrel, all the other drugs we have?
Sure, that's another great question. So for aspirin, I'm aware that I think recovery investigators, which have a large platform, are studying aspirin in a couple of patient subsets, and also in ICU patients, there is COVID-PACT, which is in part driven from Boston. But also in the UK, they have an interesting study for people with positive biomarkers troponemia, where they're receiving low-dose rivaroxaban plus aspirin plus a proton pump inhibitor. So that trial is going to be very interesting as well. I'm actually involved in another systematic summary of other trials with novel antithrombotic agents, which is currently under review, so I cannot quote the details, but I think there is more to come down the pipeline. And sulodexide, which we discussed, it's not really an antiplatelet agent. It's more of an oral heparin, if you will. But that also had positive results in a preliminary outpatient trial. So I'm curious to see if there's going to be more of trials with that agent as well. So there is hope, but nothing conclusive yet.
I have another question about vaccines, because we have seen this vaccine-induced thrombocytopenia after some vector-based vaccines. Is there any connection to the thrombogenicity in COVID-19? Have you seen any patients that also have kind of an autoimmune or COVID-induced thrombocytopenia?
That's a great question. Specifically, thrombocytopenia as a feature of COVID, not that I have seen. That being said, I'm involved in a couple of studies related to that as well. In essence, I think the risk of thrombotic events with COVID-19 itself, including cerebral vein thrombosis, is far, far, far higher as opposed to that of the adenovirus-based vaccination. And we have not seen as many of those with mRNA-based vaccines. That being said, to me, there are two pieces to it. Is this vaccine-induced thrombocytopenia a real phenomenon? Initially, people were questioning, well, maybe it is, maybe it is not. I think now, over 1 month in, all of us tend to believe it is a true phenomenon. However, in my humble opinion, the absolute event rates are so low that the risk needs to be communicated to the public and patients and policymakers, but in a way that's transparent, not just scaring them off. They have a right to know, but they also need to know what are the trade-offs, similar to anything else that we do in medicine. The absolute risk of having that serious complication is very, very low. If they don't have another vaccine alternative, the absolute risk of contracting COVID and having complications including but not limited to blood clots from COVID, are far more higher.
So maybe one other question to the treatment. Now, we talked a lot about prevention of venous thromboembolism. If a patient has caught either deep vein thrombosis or pulmonary embolism, is there any reason to shift away from standard treatment like giving less heparin because of fear of whatsoever hit also? Or would you just go with a standard treatment that has been suggested by guidelines so far outside the field of COVID-19?
So the way I would respond to this very interesting question is yes to both of your last statements. And by the way, most of the guidelines for now do not recommend heparin-based regimens as the initial therapy anymore, because what would be the reason? If somebody is critically ill, similar to the very, very sick patient that we discussed before, or somebody who's going to need pharmacomechanical therapy, etc., that I understand. Otherwise, for many reasons, including limiting the patient's exposure to the healthcare system, comfort, convenience, etc., probably a direct oral anticoagulant would be just fine. Now, the more interesting question that we haven't discussed, but I would volunteer it up, is for how long do we treat these patients? And I think that's a tough one, but for now, I think at least we need to treat for a minimum of 3 to 6 months, and then wait really to see a little more of the studies. Some of the preliminary studies do not show a very alarming high risk of recurrences. But I think after the first 3 to 6 months, it's really got to be individualized, and the unknowns should be discussed with the patients until we are informed better, and it has to be based off of shared decision-making.
Thanks a lot for this statement, because at least here in Germany, it's quite difficult to convince our colleagues that we should really start with direct oral anticoagulants. There's still some belief that it might be better to start with heparin. Maybe just to finish, 2 looks into the future. Now, the first question would be, we all hope that the pandemic will end in the not so far future. So the studies that are presently recruiting will someday have to end. Are you planning to kind of gather all this data together now that you are the one who's really globally kind of coordinating all this? Will we see a kind of consensus statement, something like that, which is already planned?
I appreciate the kind remarks. That being said, I'm just a small part of a huge team. And to your point, I think there are several groups involved in that. So I know of a couple of groups from the World Health Organization that are trying to summarize information from the trials that are coming up for anticoagulants. I know that several societies, including the American College of Chest Physicians, American Society of Hematology, European Society of Cardiology, and others are trying to summarize evidence and provide interim expert reports. As far as our own group is concerned, our internal agreement is try to essentially relook into the completed trials, maybe by another 6 months or so that we would be able to share some information. Because, for example, last year we had a multi-society consensus document that came out, and it was probably helpful at the time to say what many of the opinion leaders around the world were thinking about issues of thrombosis and thromboembolic disease in COVID-19. But more than 1 year into the pandemic, I don't think it's the right time for consensus documents anymore. We need evidence to inform our practice. And for that, we need at least a handful of these trials to be completed and the results to be disseminated. Hopefully by that point, it would be the right time to provide an updated evidence-based statement.
Maybe one last question into the future. Now, the ACC convention will start in 2 weeks. We know that some other very, very interesting data will come from you. We are quite aware that surely you cannot report on them because we will have to wait until the convention. Just for our audience, now, you did not just randomize people to intermediate dosages of heparin or standard prophylaxis doses. You also randomized upon statins or no statins. Maybe you could just, without giving any results, surely, just give us the idea, and maybe also the idea why you, if I got it right, kept the same endpoints, which are actually rather thrombotic endpoints.
That's a very interesting question. So to begin with, many people have been interested in statins in many other indications, if you will, outside of the direct cardiovascular risk reduction. Even for people with pulmonary fibrosis, ARDS, etc., there have been several studies, one of the important ones being the HARP2 trial. Granted, it did not meet the primary outcome in the initial study, but they published a subsequent analysis that showed in people with hyperinflammatory phenotypes of ARDS, statin therapy conferred benefit. So it was the same spirit that essentially drove us, maybe a little bit of reduced inflammation, maybe improved lung function, and probably some reduction in thrombotic events, and knowing that statins generally have a good safety profile for the short term. It really drove us to do the second randomization to atorvastatin 20 milligrams once daily versus placebo. And we knew to begin with that some of the patients who are being enrolled for the anticoagulation hypothesis are not going to be eligible for the statin hypothesis because they had a pre-existing strong indication to use a statin. So we pre-specified that if we didn't hit our target sample size, even after completion of inspiration, the anticoagulation, we will continue to enroll for the statin hypothesis. That is what we did. Stay tuned. In 2 weeks or so, we will be sharing the results in the American College of Cardiology meeting.
So I guess it's Sunday in 2 weeks exactly. It's the 16th. And for all our German colleagues, we are planning to discuss your results and some other results from the ACC on Wednesday, the 19th of May on 7 p.m. So all our German colleagues are invited to that live event. So thanks a lot for all your work that we really appreciate deeply. Thanks for taking the time on an early Sunday morning in Boston. And maybe someday you will find another half an hour or so to keep us updated what's going on with heparin and also what's going on with statin. And hopefully see you then again. Thanks a lot.
Of course, lovely being with you. Thank you so much. Have a good evening.